So this is a 24-year-old nulliparous Hispanic woman, no past medical history, presented in labor at term, really had been uncomplicated. Labor was uneventful. Next slide. And 12 hours after delivery, she started complaining of chills, diaphoresis, right-sided back pain. Became febrile. Heart rate was slightly elevated. Again, a very common finding immediately postpartum. And then you throw in the fever, and that certainly accounts for that. Blood pressure was slightly elevated, but normal, and respiratory rate also normal. On physical exam, she did have significant right CVA tenderness. So obviously you think immediately that this patient is having evidence of an upper urinary tract infection. The laboratory workup revealed an elevated white count, and the UA looked like there was a significant amount of blood with leukocyte esterase and a significant number of white cells. She was started on antibiotics, as one should be, for presumed pyelonephritis or upper urinary tract infection, with a broad spectrum cephalosporin. And I'm going to, Michelle, if you're still with us, I'm going to let you kind of walk through this case from a nursing standpoint and a physician standpoint, and just kind of go through the bundle that we talked about.
So what we've done is we've pulled in the first part of that algorithm or the flow chart. So our initial, we have a suspected infection. We already know that. We're doing routine vital signs and white blood count screening. So that initial sepsis screen, we're going to look at those 4 criteria. And what we see is that she rules in for the screen, and you can advance the next 2 to get the little arrows to pop up. So we've got the elevated temperature and then her white blood cell count. So now, because we've got 2 screens, we're going to move to the next level. So we're going to start those antibiotics. We want to make sure she's got plenty of fluids. And then we're going to go into part 2 of this, the second step of the screening, which is confirmation. So it'll flow through as we get.
Yeah, just go ahead with the case there.
So you can see on the slide, we've got patient starts complaining about extreme difficulty breathing, non-productive cough, generalized, just I don't feel good. We've got her vital signs there for you. She does get a chest x-ray, and we started blood cultures and urine cultures, and they both grew E. coli. So when we look at the confirmation of sepsis, we want to recognize what does she screen in, and you only need to have 1 factor to screen in now at this point. Did you want to add anything else, Dr. Campbell?
No, that's exactly right. I think the key is to blanket the patient with an evaluation, but it's becoming obvious.
So now
and then she becomes intubated. So
that's now our confirmation when we look at that, because I don't have, for this case, we didn't particularly have some of the labs. She probably screened in at the 36-hour mark, but now at the 40-hour mark, she's definitely screened in because of the intubation.
And this is a case where there's a natural progression, and I have to warn people, I see this not infrequently from cases that we have referred in. We're pretty quick to start antibiotics, but I see some patients with an immediate postpartum fever and slightly elevated white count and heart rate, and they decide not to start antibiotics immediately because they think that it could just be peri-delivery febrile episode. I just think that we're beyond that now, and we need to be very quick to proceed with antibiotic therapy, and that's where we can make a difference with the significant impact of infectious causes for maternal mortality today. This patient, interestingly, progressed even with the use of antibiotics, which can occur. And this patient with upper urinary tract infection developed really some respiratory components. Is it ARDS? Is there heart function problems? And in this particular case, you see the ejection fraction is significantly impaired. She has ventricular dysfunction with hypokinesia and a chest CT, ruled out pulmonary embolus, which is very important to do, because remember, these patients can have dual processes going on. They can have a significant infection and they are at risk, then even higher risk of venous thromboembolism. So you have to make sure that that's not the case. So this patient definitely is ruled in for the picture of sepsis, given the respiratory and cardiac issues that are going on. Go ahead and forward this. So, okay.
There we go.
And
we see she goes through her normal process of, okay.
we hope
just lost.
we hope the normal process of improving, if we, and sometimes you can do all the right things and they still don't improve, but this patient did improve and was extubated. So,
and as we move through her postpartum days, she did go home on finally postpartum day 11. So the next slide goes into a little bit further, which I wanted to highlight this because I think this sometimes happens with our patients, that she came back at postpartum day 21 into the emergency department. So we do want to consider where our early postpartum moms are presenting and how quickly OB is being consulted with an early delivered patient. So she did have continued shortness of breath, difficulty walking upstairs, but said that she was taking her medications. And then the last bullet on this slide, and I'll let Dr. Campbell talk more about this slide, but when the last note, the patient did not return to that particular medical center, and so they were unable to contact her despite multiple attempts. That leaves a lot of stress to the care providers who do want to provide that follow-up care. So we do want to make sure we highlight, again, not just the importance of self-care, but the importance of good follow-up for our patients when they are finally discharged out of our care.
and this is an unfortunate circumstance that we see with our patients, particularly as we have more and more patients that don't speak English as a primary language, or they're not from here, and they disappear for care. It's an area in healthcare in the United States that we're woefully deficient on. Many of the other industrialized countries have more use of community health workers and follow-up for discharge planning and discharge follow-up, and just assuring that the patient understands the importance of this is critical to a good outcome, because this patient's mortality risk within the first year after this delivery is still tremendously elevated because of the cardiac dysfunction and the continued symptoms that she has up to postpartum day number 21. So it's very disheartening that she didn't have, or we weren't able to get in touch with her for follow-up. So I'll pass that on to you, Michelle.
So this comes from the clinical expert series that was in August Green Journal, and I thought it was just absolutely perfect to be able to throw in here. They list, it's a great article. I would highly recommend everyone gets it and reads it, but it does have the top 10 pearls for the recognition, evaluation, and management of maternal sepsis. You can see that the pearls are on the left-hand side. So recognition, moving fast, and beyond the golden hour. So that escalation of care being extremely important, stabilizing the patient and figuring out the source of the problem. And then they also listed the risk factors for maternal sepsis. And I just wanted to highlight that and have everyone look to see how many patients do you have that have risk factors pregnant patients with risk factors, and we think about who we care for and see on an everyday basis. That there's patient factors and then there's the specific OB factors. And so I think that information making us, number one, much more aware, and then having a system in place to do that early recognition, that early communication, and the early escalation of care, I think is really kind of nice, puts a nice little bow on what we need to be paying attention to for these patients.
I know our time is short. We are happy to stay on and take comments or questions. Did you have the next one up there for our next echo too? I can't remember. Yeah, isoimmunization is our next topic. I think Dr. Johnson's going to be presenting that. And if you have any other topics, we're going to go through and present some hot topics in obstetrics. Please contact Rachel if you have any other topics that you'd like for us to cover. We'd love to do what you want us to do. We want this to be a positive educational experience for everybody. So thank